Good evening, this is Sarah Martin. I am presenting a case study for 626C, Care of the Pediatric and Woman. I have a case study of a 44-year-old female who presents to the clinic today for an annual yearly female exam, to establish a primary care provider. She states that she has not had an annual physical since having her children some time ago and would like to establish care. She also states that she has been having multiple issues. She has been struggling over the last several years with weight loss and obesity. She has previously been seen at Well & Company in Alexandria and has had some lab work and is being treated for weight loss was being treated for weight loss at that clinic. She was started on Ozempic after months of struggling to lose weight with diet and exercise. She did not have any effects with weight loss after starting the Ozempic after several months of dosing. She was then switched to Mounjaro, which she has noted good results and has had an overall improved effect on the Mounjaro. She has had approximately a 10 to 15 pound weight reduction on the Mounjaro, with her highest known weight at 298 and her weight today was 276. She does report an increase in fatigue and insomnia. She states that she can fall asleep without problems in the evenings and afternoons, but wakes mostly due to exhaustion in the afternoons, wakes frequently throughout the night and has trouble going back to sleep. She also states that she would like her hormones drawn today to verify if she's perimenopausal or if some of her symptoms of hair loss, fatigue, and weight gain are due to hormone fluctuations or early menopause. She is status post partial hysterectomy for bladder repair. She is status post partial hysterectomy and bladder repair from a prolapsed uterus and bladder. Approximately 10 years ago. Her mother went through menopause at the age of 40 years, and she states that she had began menstruating at the age of 9. She denies any sort of hot flashes or night sweats. She also states that she has had chronic vaginal discharge noted for the last several years. She states that she's been struggling with this for some time now and has had several workups with sexually transmitted infection testing, which all came back negative. She is in a monogamous relationship and married to her husband, so she has no concerns of any sort of sexually transmitted infections. But she is sexually active, however. She states that the discharge from her vagina is clear and white in color. She notices that it is the worst at the beginning of the day. She also states that at times there is an odor, but not a fishy odor. She states that she does have some issues with incontinence continued after her bladder repair. So she says that sometimes the odor can smell like ammonia, which she is unsure whether that's urinary incontinence or the vaginal discharge. She was taking boric acid vaginal suppositories in the past, which seemed to help somewhat with some of her symptoms of the vaginal discharge, but only masked the discharge and seemed to come back immediately after stopping using the suppositories. She is also status post right lumpectomy from a suspicious lesion approximately 20 years ago. She wishes to have a 3D mammogram today to reduce the pain during her exam, and as her right breast is still tender from where her lumpectomy was performed. She does state that she has more hair on the right breast than the left. She occasionally does breast self-exams at home, but is not consistent. She has never had a mammogram in the past, only ultrasonography. She also states that she wishes to have a varicose vein consult referral placed today due to having varicose veins, which are hereditary. Her review of systems: constitutional was negative, AGENT is negative, cardiovascular denies chest pain, palpitations, respiratory denies any shortness of breath, GIGU, daily bowel movements, occasional constipation, daily vaginal discharge, as stated in the HPI. Neuromuscular negative, skin negative, heme lymph negative, endocrine immunologic negative, and psychosocial behavioral negative. Patient's physical exam: constitutional, alert, well appearing, normal affect, skin normal color, no rashes or suspicious lesions, pupils are equal and round and reactive to light and accommodation, extraocular movements are intact, normal external ears, canals, tympanic membranes bilaterally, no normal nose, normal nasal mucosa, no nasal discharge, normal oral pharynx, teeth and gums. Neck is supple with no thyroidomegaly, adenopathy, or masses. Chest is normal in appearance. Lung sounds are clear throughout, bilaterally with no rales, wheezes, rhonchi, or rubs. Cardiac exam, regular rate and rhythm, no murmurs, rubs, or gallops. S1 and S2 are normal, no lower extremity edema bilaterally. Abdomen soft and non-tender, no masses or hepatosplenomegaly. GU, pap, and pelvic exam were performed today. Cervical os mucosa within normal limits. Small polyp noted on the cervix at the 5 o'clock region. No drainage was present during the exam. Bimanual palpation. My manual exam was done with no tenderness noted on palpation or abnormalities. Lymphatics, no cervical adenopathy. Musculoskeletal, normal inspection. Palpation, range of motion, strength, and upper and lower bilaterally. Psych, alert and oriented times 3. Memory is intact and normal affect. Problems and concerns with this case study. Some health promotion teaching that was discussed during our visit today was the importance of yearly screening exams and health promotion exams. Patient was scheduled today for a 3D mammogram and will be performing that next week, and then she was also encouraged to continue with yearly mammograms given that her age supports that. We also discussed the need for every 3-year pap screenings due to her cervix still being present even though she is DAS post partial hysterectomy. We did also update her screening vaccination, or her health maintenance vaccinations. So we updated her tetanus today, and she is up to date on her COVID and her influenza vaccinations and all other vaccinations for her. Even though obstructive sleep apnea screening is not a regular health promotion screening, we did also set her up for screening for obstructive sleep apnea given her symptomology. We also did yearly screening lab work, given that the patient has obesity and just her weight alone predisposes her to to the likelihood of type 2 diabetes, obstructive sleep apnea, and also hyperlipidemia. Some strengths and weaknesses of the encounter that were identified. The patient is responsive and eager to change her current habits. She's also actively attempting to lose weight. She's eager for screening measures to be performed. She sought out our clinic to schedule her screening measures to take care of her vaginal discharge, and she also was very eager to get her mammogram scheduled. Weaknesses identified would be that her compliance and delay in seeking care for her current issues. She did wait a long time to rescreen and to be seen again for a pap or pelvic, and also to be seen for mammography, especially considering her history of having a lump removed from her breast. Identify 2 organizations that could play a role in health promotion and disease prevention for the client. Local area gyms and weight loss groups would be beneficial for this patient, given her propensity for obesity and her current attempts at weight loss. Our local clinic is a great organization for her to pursue her screening measures, such as her mammograms, her pap smears, her vaccinations, and her yearly lab work. We're all able to do that. And then when she does meet age criteria for her colonoscopy and any of those other screening measures. So one article that I did note in regards to, I felt like the biggest issue for her was her likelihood for obstructive sleep apnea and the risks that plays on her weight loss and also her health overall related to her obesity. According to an article from the Endocrine and Metabolic Clinic of North America, obesity and obstructive sleep apnea are intimately linked. Obstructive sleep apnea can predispose patients to disrupted metabolism, daytime somnolence, and disrupted sleep patterns, all of which the patient has been experiencing. These disruptions increase the likelihood of patients being obese and staying obese unless their underlying obstructive sleep apnea is treated. So really that means that unless she gets her obstructive sleep apnea treated, she probably won't lose weight enough to really make a difference, thus predisposing her to other issues and her continued fatigue, her continued somnolence, her continued issues with insomnia as well. And that is it. Have a good day.